The first talk is by Dr. Raj Narayan.
Good afternoon, everyone. Once again, thank you to AIOS for giving me this opportunity to share. It's not a new technique, but not commonly described or used technique. I'd like to acknowledge my fellow Khushbu in this particular study. So, complex retinal detachments and recurrent retinal detachments are not easy to manage. We have various options, peeling membranes, or doing retinectomies, leaving PSCL inside the eye, but still they have a very high failure rate. And after every recurrence and every resurgery, the chance of reattachment keeps going down. While a lot of other adjuvants have been described, uh, antimetabolites and dexamethasone, and recently intravitreal methotrexate has been advocated and also being used by quite a few people, but it still requires multiple injections over many months, and the success rate is quite variable. And these injections have to be given repeatedly in these patients under silicone oil. And all these retinectomies in very, very difficult cases, uh, they do help, but they are also prone to recurrent detachment, especially these inferior retina under silicone oil, because silicone oil is lighter than water. All the PVR changes and recurrence under oil happen inferiorly, whereas if you use heavy density silicone oil, you are going to have superior recurrence of retinal detachment. Same thing which happens inferiorly will happen superiorly in heavy density silicone oil. So this is kind of a challenging case that I am going to describe, where a patient had an open globe injury which was repaired, and all the retina is incarcerated on one side into the corneal wound. What you are seeing here is bare RP and choroid. I hope it's visible on the screen. So this is how the retina is looking, and with a bimanual maneuver with forceps in both hands, we have to open this funnel, which is not easy. It took a long time to open this funnel, and these are the kind of tough cases where we are looking at different options, including the silicone oil and PFCL layered sandwich technique, which I am going to show, because these cases are prone to redetachments. This is a young boy from the Gulf who had Stickler syndrome. What you can see is this is all retina actually here. This is a funnel retina, and this is all bare RP, which you can see here. The retina is all on one side, and initially I had injected full PFCL in the vitreous cavity and left it for about 2 weeks. I thought I will leave it, but the patient or the boy presented in a week's time where the superior retina has detached under PFCL. So this is the GRT edge. This is the original laser marks in the bare RP, but the retina has slipped and detached inferiorly. And then I had to do a PFCL silicone oil sandwich. You can see inferiorly the edge of PFCL, superiorly silicone oil. You can see a nice reflection of the disc and retina in the inferior PFCL. So we have analyzed our cases. The first case I did was in 2013, and I have collected so far 34 eyes, and the kind of detachments were varied, including post-trauma, funnel RDs, recurrence under silicone oil. Two were done with endoscopic maneuver. The pre-op visual acuity was very poor, hand motions. Only two eyes had better than 2400 in this series. So the anatomical success rate after the sandwich technique was 96% in 1 week, and at last visit was 91%. The visual acuity on average improved by 3 lines, but still it was not great. At the end of the last visit, it was logMAR 2. But what you can see here is that 8 eyes had better than 2400 vision compared to 2 eyes at baseline. So some improvement in vision also is noted in these eyes. And this is that boy which I had mentioned who had sticklers from Gulf who had come. We had to do a lensectomy, and you can see the 360-degree giant retinal tear. You have to be very meticulous in these cases with the PVR. You have to do a thorough job of cleaning up any subretinal or epiretinal membranes, or if there is a retinal contraction, you have to cut the retina so that it can relax. So under PFCL, I used forceps as well as finesse loop to clean up all the membranes, and peripherally wherever there was a contraction of the retina, I had to do a relaxing retinectomy radially. And at the end, we left. I generally leave about 1/3 of PFCL in the eye, and the rest of it is silicone oil. So uh, this was what initially I told that the boy had superior recurrence, and then I had to take up again, and this time did a little bit of retinectomy and injected silicone oil, and PFCL about 1/3 was retained, and this is how it was looking post-operatively. This is another case. Patient has a multifocal IOL, and this is under oil. Patient already had been operated with belt buckle, vitrectomy, silicone oil done twice outside. There is a break inferiorly, lots of PVR. So this surgery is being done under silicone oil. I am removing all the membranes and injecting perfluoron dual bore cannula under the silicone oil. And aspirating some amount of subretinal fluid with a soft tip, and then again inject some more perfluoron under silicone oil. And as I said, generally about 1/3 of eye is left with PFCL. And this is how the pre-op under silicone oil. This patient had extensive PVR. She is also a high myope, and this is post-operative. This is another gentleman who had retinal detachment, choroidal detachment, uh, left PFCL in the eye, but in these cases, earlier I used to remove the PFCL in about a month and then completely fill with silicone oil. But in this patient, after removing the PFCL and injecting silicone oil, it redetached again. So I have left him with PFCL and oil sandwich now for many months, and these are some other cases. So in conclusion, splash is a promising option for managing complex retinal detachment cases with advanced PVR. We did not see any toxicity in these patients. Some of these eyes have had PFCL for almost a year, and I have left them in the eye. They also have severe hypotony, some of them, but it does not cause any toxicity. You just leave it, and whatever vision they have, they are able to maintain that. With that, I thank you for your kind attention.
Sir, Dr. Aryan. So great talk. Just one question. So at what stage will you ever envision removing PFCL, or will we just leave it forever? And does the thought come that at some point of time you will probably replace that residual PFCL also with oil?
Yeah, good question. So earlier I used to remove the PFCL, as I said, in about 2 to 4 weeks time. It's not easy to remove the PFCL. One, it becomes very viscous like silicone oil, and it's like a heavy viscous liquid, so you can't aspirate, doesn't float up. So removing them may be difficult unless you really go in 2 to 3 weeks time. But now I don't remove it. I just leave it. It's safe. And these are cases which need chronic tamponade. This is not a routine surgical technique. You should not be using this in all recurrent PVRs or complex RDs. But where there is very advanced PVR, retinectomies are required, and you feel that these patients require long-term tamponade even with oil. So I just leave the PFCL and silicone oil in the eye, and I don't remove them. I just leave it in the eye.
Can I just have one more question? And any thoughts on the fact that does it lead to more emulsification somewhere down the line of the oil, or any changes in the emulsification pattern?
No, I haven't seen emulsification either of PFCL and I use 5000 in these because I know these are long-term cases. Even if it's just oil fill, I leave them with 5000 and they don't cause any problem, and I haven't found any problem. The only problem is the mixture of PFCL and silicone oil. So you won't be able to remove it in many cases, even if you want to after a month or so.
Thank you.
Dr. Shanmugam, any comment on this?
I haven't used this particular technique, but theoretically I find some issues like what do you make the patient lie down? So, because both are convex menisci, there is one rim of fluid between the two menisci. So that's something which can interfere wherever, if the break is somewhere in that, the fluid can go, that's what. And if the patient lying down, then the PFCL goes posteriorly if the patient lies down supine and the oil comes anterior. Sitting position, then the whole dynamics changes. So that's another reason. So I'm not too sure like if it gives me an added advantage. And sometimes when we have left behind inadvertently PFCL and silicone oil, they form one kind of a gooey mixture, which is extremely difficult to remove. And particularly if a little bit of viscoelastic also goes, it's extremely gooey and it becomes very, very difficult to remove. So right now, what you have said, I usually leave behind perfluorocarbon for about like a month, and subsequently either remove it if everything is fine or replace it with silicone oil. So I don't have a personal experience. I'm sure like Raja has shown that very good results, but in my hands it has not worked.
Yeah, I think it's good to use it during the surgery. I have used it during to be able to do laser, because otherwise, as you remove instruments, the PFCL starts coming out. If you have a layer of oil, it stabilizes the globe and allows you to do laser completely. And then you can remove PFCL at the same time if there is not advanced PDR, and fill up with oil. So I feel per-operative sandwich technique is also an option rather than just leaving it post-op only. Great.
Okay, thank you.
Thank you so much.